including the development of long-term end-stage renal disease, or CKD. So to take a step back in history, this was the system actually that I was trained on back in the late 1980s, early 1990s on CRT. So this predates many of you in the room, I think, but nevertheless, it's important to have this historical context as we talk about contemporary devices. So in this system, it's basically a conglomeration of different standalone components that are largely adapted from chronic hemodialysis technology. And in fact, there were, although we didn't know it at the time, there were many safety concerns related to this type of system that have been addressed in more modern devices. And one of the biggest concerns in retrospect is the way that fluid balancing, such as it was actually done. So in this system, which was typical of the systems in the late 1980s, was a nurse essentially was the fluid balancing system, because the nurse collected the fluid on an hourly basis and then compared what was prescribed by the physician to what was actually collected in this ultrafiltrate device. But there was no communication between the ultrafiltration system and the fluid infusions, in this case replacement fluid. So there was a large possibility for fluid balance errors and the resultant hemodynamic instability that could occur. So as the therapy has evolved over the past 25, 30 years or so, we have to recognize that largely back in the late 1980s and that time period that I was just mentioning, CRT was mostly limited to being a salvage therapy. In other words, when either hemodialysis was not even an option, or when hemodialysis had been tried and failed. But as time has gone by, we've gotten away from simply using chronic hemodialysis technology, and we've developed systems that are specifically addressing the clinical issues that pertain to critically ill AKI patients. And again, the fundamental aspect of CRT is not, so to speak, rocket science. It's simply that the treatment is prolonged, allowing for lower rates of fluid and solute removal, and then in turn allowing for greater hemodynamic stability. And these improvements in technology, which we'll discuss, have led to, in many ICUs, particularly larger ICUs around the world, to CRT being obviously no longer a salvage therapy, but the preferred first-line therapy, again, in many ICUs. So if you look at the basic aspects of a modern, contemporary, latest generation CRT device, you'll recognize that it's vastly different from the system that I talked about 2 slides ago, the kind of jury-rig system. So very importantly, we'll go through these various steps. First of all, essentially all fluid pumps and the blood pump are incorporated into the device itself, rather than being standalone components that don't talk to one another. Secondly, there are dedicated disposable circuits that can be used for when different modes of CRT are applied. Thirdly, there have been major advances in the user interface that the nurse who's applying the therapy can apply. And also, there have been major advancements in the safety features that are incorporated into these devices, and particularly from a fluid balancing system. So you recall from the previous slide the very crude and rudimentary way in which fluid balancing was done in the system that I described. And even compared to conventional hemodialysis systems, which use so-called volumetric fluid balancing, the so-called gravimetric or scale-based CRT devices that are used in contemporary practice continuously monitor the fluids that are used in the therapy, whether it's fluids that are infused, replacement fluid or dialysate, or the effluent. So those fluids are continuously weighed and any discrepancy between what's been prescribed by the physician and what's actually being measured by the scale, then via the software in the machine, then is fed back to the various pumps. And if adjustments need to be made to correct any discrepancies, then the software in the machine takes care of that. And finally, an aspect of many of the latest generation devices is citrate anticoagulation functionality, which includes, for instance, not only the coupling of the blood and the citrate pumps, as we'll talk about why that's important, and also functionalities that allow for calcium reinfusion and calcium management. So, compared to the systems that were used when I was training as a nephrologist, we have made leaps and bounds in terms of the sophistication of these devices and the safety aspects along with the user friendliness. Now, to turn to the data regarding modality use in AKI, this is just a summary of one of the many meta-analyses that have been done. I think this well summarizes that the literature or the studies that have tried to compare intermittent therapies with CRRT have all been, in one way or another, highly flawed. So it's hard to really apply the data, especially to modern practice, when many of these studies were done now as many as 20 or 25 years ago. And if we look at one of the major studies that was done in this field, it sheds light on, I think, the way that most clinicians regard conventional hemodialysis, SLED, and CRRT. So the protocol of the ATN trial performed in the United States, which of course was a dose trial, expressly forbade the use of conventional hemodialysis in patients who were hemodynamically unstable. So in other words, only patients who were hemodynamically stable based on the SOFA by protocol could be treated with conventional hemodialysis, whereas patients who were unstable, according to the SOFA score, were mandated to be treated with either SLED or theoretically or with CRRT. But in fact, what happened in the unstable arm, 95% of the treatments were actually delivered according to physician choice. 95% of the treatments were delivered with CRRT, and only 5% of the treatments delivered to unstable patients were provided by SLED. So again, this was very reflective of U.S. clinical practice at the time, and largely as reflective of current clinical practice also. And another thing that we learned from the ATN trial was the actual extent to which intradialytic hypotension occurs with conventional hemodialysis. I remind you that patients who were treated with conventional hemodialysis in this trial were, by protocol, at least at the beginning of a treatment, had to be hemodynamically stable. In spite of that, you see the very high incidence of hypotension, almost 20% in both the arms, and in fact, a significant number of treatments had such severe hypotension that actually the treatment had to be terminated. And the clinical implications, or the potential clinical implications of hypotension during dialysis are shown, at least to some extent, by this trial. So this is the Canadian trial published by Wald and colleagues a few years ago. So fairly sophisticated statistical techniques to at least try to make sure that the two patient populations, even though it was an observational trial, that the two patient populations were more or less clinically equivalent at baseline. And the data clearly showed that for those patients who survived at least to 90 days after the initiation of renal replacement therapy, there was a significantly higher development of the need for chronic dialysis in patients who were initially treated with conventional hemodialysis versus CRRT. And moving on and then talking about the management of fluid overload with different modalities. These are data from the Finaki trial that involved the use of both conventional hemodialysis and CRRT. So irrespective of the modality, the extent of fluid accumulation during the patient's course in the ICU prior to the initiation of renal replacement therapy, you can see that the extent to which that occurred was directly related to 90-day subsequent mortality. And in fact, these more recent data from Korea zero in on this fluid overload issue and specifically kind of demarcate patients who are considered primarily to have septic AKI versus other forms of AKI. And in fact, it was the patients who had septic AKI in whom this fluid overload was particularly harmful, as you can see from the left-hand curve. So the management of fluid overload in turn becomes a very important issue. These are familiar data probably to a lot of you from the Picard trial in the United States. Again, observational data, but I think this information is very consistent with clinical practice in that the patients treated initially with CRRT, there's a steady improvement in the degree of fluid overload, whereas in fact the patients who were initially treated with conventional hemodialysis, in fact there was no improvement in fluid overload. In fact, there was a deterioration, and there are a number of potential explanations for these data, certainly. So to summarize then from the KDIGO AKI clinical practice guideline, there are a number of recommendations and suggestions that are made based on the varying level of evidence, but I think one of the more important ones was coming from this expert group was to suggest that CRRT, at least relative to conventional hemodialysis, should be used in patients who are hemodynamically unstable. And again, this is very consistent, for instance, with the protocol of the ATN trial, and it's very consistent with, in most cases, general experience in clinical practice. So we'll move on now to dosing of CRRT. This is a relatively settled matter in the field of renal replacement therapy for AKI. Of course, this was a study from Ronco and colleagues in Italy, single-center trial, that really revolutionized CRRT in a relatively short period of time. So relative to a kind of conventional dose that was being applied at the time that the study was initiated, and that was prescribed dose of about 25 milliliters per kilogram per hour, in that range. Higher doses were statistically associated, significantly associated with better outcomes in this particular trial. And as I mentioned, this trial really had almost an immediate impact on clinical practice because the dosing parameter that was used in the trial, effluent rate normalized to body weight, was almost immediately incorporated into general clinical practice. And sometimes we tend to forget that was, before this trial was published, there was never really any dosing parameter that had been established. And after the Ronco trial, there were a series of single-center trials, the ATN trial, the renal trial from Australia and New Zealand. When all those trials and all the data from those trials were compiled, essentially the recommendation on a consensus basis then was a delivered dose target of 20 to 25 milliliters per kilogram per hour. And this is just reflected in this fairly recent Cochrane analysis, which, if you look at 30-day mortality, there's certainly a trend in favor of higher dose of CRRT, but the result with a compilation of the data, the differences were not statistically significant. And from a more practical perspective, actually incorporating the guideline information into clinical practice, what really has been the emphasis over time has been obviously keeping in mind what the delivered dose target is of 20 to 25 milliliters per kilogram per hour. But then from a more practical perspective, how do you make sure that, in recognizing that in many patients there's going to be a discrepancy between the prescribed dose and the delivered dose, how do you ensure the delivery of the dose in that 20 to 25 range? So these are data from the so-called Do-Re-Mi study in Europe, observational trial, which suggested, and consistent with other observational data, that there is typically about a 20 to 25% difference between the prescribed dose on the one hand and the delivered dose of CRT. And this is an important trial from the Picard group that, and sometimes with this fact kind of gets glossed over, and obviously this is an important point relative to citrate anticoagulation. But every